Good afternoon, everyone. Thanks for coming to our event on telehealth. My name is Daniel Castro. I'm a senior analyst at the Information Technology and Innovation Foundation, a nonprofit, nonpartisan public policy think tank here at DC that does a lot of work on innovation and technology policy. A snowy day like this reminds us of the benefits of telework and telepresence and all these teletechnologies. So it's a good day to be doing this event. I'd like to welcome Congresswoman Doris Matsui and Congressman Bill Johnson, who's joining us momentarily, to kick off today's event and talk a little bit about the legislation they've introduced and how this is really going to help accelerate the adoption of telehealth across the United States. Congresswoman Matsui has represented the city of Sacramento and its surrounding areas since 2005. She served on the Energy and Commerce Committee, co-chairs the Congressional High-Tech Caucus, and has really been one of the leaders in crafting legislation to address technology, consumer protection issues, and healthcare, especially mental health. Congressman Johnson, who joined us, has deep expertise in the private sector in IT management. He previously co-founded an IT consultancy, as well as worked as the CIO of a global manufacturer. He also serves on the Energy and Commerce Committee, where he too has been an important voice on telecom and healthcare issues. Congressman Matsui, please.
I have a vertical challenge here, so I need my little step here. Hi Bill, how are you? I'm doing fine, yeah. Well, okay. We're very formal here, I can tell. But I want to thank you, Daniel, very much for the kind and generous introduction, and thank you for inviting me to join you here today. I just want to say this: American innovation is transforming healthcare. American innovation is exciting anyway, but what we're doing in technology is really an underpinning to all the sectors, healthcare being one of them. It integrates science, medicine, and technology to provide individuals with real-time access to vital health information, much of which was previously unavailable outside of a hospital or a doctor's office. But we all know that house calls are really a thing of the past. Whoever heard of them recently? Virtual checkups are becoming the new digital age house call, and doctors are using iPads to issue prescriptions and diagnose patients. Smartphones are creating a new pathway for virtual interactions between doctors and patients. Texting between doctors and patients is becoming more commonplace. However, with all these advances, there is still room for improvement in our telehealth systems. In some cases, it's safe to say that Amazon knows more about us than our doctors. True, right? Telehealth is at a critical juncture of issues of primary care shortages, specialty care deficiencies, and difficulties attracting and retaining health professionals. These continue to rise. Now more than ever, it's crucial that the nation leverage innovative technologies to bridge these growing gaps in care. Just last week, I visited the Center for Health and Technology at UC Davis Health Systems in my district in Sacramento. The center is widely regarded as a leader in the advancement of telehealth technology. They have provided over 35,000 telehealth consultations in over 20 different specialties, and they continue to push the envelope. One example they brought up is a woman named Alice, a diabetic for over 40 years who'd been injecting nearly 300 units of insulin a day. Sometimes her blood sugar was so high that it couldn't even register on a monitor. And despite her best efforts, diet and exercise were not helping. Her vision was poor, and her kidneys were deteriorating. Alice needed to consult with an expert endocrinologist, but the 350 miles between her home and Sacramento was certainly an insurmountable distance to travel for her. Fortunately, telehealth services were able to offer her access to the expertise she needed. A UC Davis specialists yielded a critical clue to Ellis's condition. Scar tissue from using the same injection site had prevented her body from absorbing insulin. Ellis's insulin usage is now 20% lower, and that chalks that up to her positive telehealth experience. As Ellis's story shows, and there are many Ellis's also, her story shows by removing barriers to care such as provider shortages, distance, mobility, and time constraints, telehealth is and will continue to be invaluable in helping to resolve some of our nation's most pressing health disparities. Of course, this is all subject to Congress ensuring that the legal and regulatory environment catches up to and keeps pace with this game-changing technology. The current problem with existing telehealth standards is that there is no consistent standard. What we have is an inconsistent and often dated patchwork of state laws. Over the last year alone, 40 states have considered legislation addressing telehealth policies with wide variations in how telehealth is defined. This inconsistency hinders the national deployment of telehealth, hurting those who need care the most. This impacts populations such as disadvantaged communities with above average rates of chronic conditions like heart disease and diabetes, and senior citizens dependent on a decreasing number of primary care providers participating in Medicare and Medicaid. Amidst the growing demand for care and a decreasing number of primary care physicians, we face a moral imperative to move beyond outdated healthcare delivery models. That is why I, along with my colleague, Congressman Bill Johnson, introduced a Telehealth Modernization Act to create a workable definition for telehealth services. This is a bipartisan measure. We all can work together, and Bill and I certainly have. It lays out principles using a highest common denominator approach for states to use when modernizing their existing legislative and regulatory frameworks. It provides a strong incentive for states to adopt consistent standards to remove the regulatory barriers to telehealth so that all Americans are able to benefit from these technologies. Now, I'm pleased to turn this over to my colleague, Congressman Bill Johnson from Ohio. Given his extensive background in business and technology, he also recognizes the future potential for telehealth and the need for a regulatory framework that will help it reach its full potential. Bill?
I like that. I've always wanted to be taller. I love this.
It helps, right?
Yes, it
You
does.
can always use mine.
It does. I feel like I have a different perspective of the world. That's great. Doris, thank you so very much. I'm very proud to be working with you in this telehealth sphere. And I want to thank you for your leadership on this issue as well. This is an example. You hear too often today across the airwaves that Republicans and Democrats can't work together. Well, there are some of us who defy that and come together to do the right things for the right reasons, and I appreciate working with you on this issue. And I want to thank the Information Technology and Innovation Foundation for giving me the opportunity today to talk about the incredible potential that telehealth has to offer. First, however, I must tell you that this topic never fails to energize me personally. Having worked in the IT industry for 30 years, I know firsthand the benefits associated with technological innovation. I always love the reaction when I ask this question. Do you know how many things a computer can actually do? Anybody care to guess? Only two. Only two things. And everything else that you see, whether it's telehealth, or what flows across your iPad, or what data flows across your iPhone, is based around two very simple operations: adding strings of ones and zeros together, or shifting strings of ones and zeros one direction or another. It's a very simple concept, and yet technology gives us the opportunity to do so many other things, providing us with access to unbelievable amounts of information, coalescing information, and using it to make smart decisions. And with this background, I couldn't be more proud to represent a state that recognizes the potential for telehealth and is continually working to nurture a favorable regulatory environment to move telehealth opportunities forward. In fact, just last month, the Ohio Senate unanimously approved a state bill which would require the Ohio Department of Medicaid to establish Medicaid reimbursement payment standards for telehealth services in the state of Ohio. Advancing this technology will have a resounding impact on rural areas around the country, especially one like mine, the Appalachian region that I serve in eastern and southeastern Ohio. If any of you have been to that region of our country, in some places your closest neighbor is 10 miles away. I have counties that don't have, some that don't have any medical facilities, others that have very few. They struggle with access to hospitals and emergency care and physician specialties, among other challenges. Extending quality medical care and expertise to these rural areas by developing telehealth services is crucial to improving health outcomes and driving down healthcare costs, which we know is a big issue today, driving down those costs through greater efficiency. And it's my hope that this technology will also attract a greater number of doctors to rural areas, closing the gaps that exist today in the area of urban versus rural healthcare. I've had great opportunities to see telehealth at work firsthand during visits to clinics throughout eastern and southeastern Ohio, and I know that it holds significant promise for rural communities and for Ohio seniors that have limited mobility to reach some of these faraway healthcare facilities that they have to try to get to. I saw a telehealth demonstration, two of them, in fact. I sat on both ends of it. One of them was in Lawrence County, where we conducted a demonstration of a telehealth session with some providers from Nationwide Children's Hospital in Columbus. It was just a demonstration. But I also saw it from the other end. I don't know if you're familiar with the neonatal cardiothoracic unit there at Nationwide. They do some unbelievable work on these tiny premature babies, operating on their hearts and helping those children move through the stages. And it's almost a miraculous thing to see the beginning and then go to the other stage at the end and see those laughing, cuddly, almost toddlers by that point, getting ready to leave the hospital. It's almost miraculous. Excuse me. It's almost miraculous. And what they've done is that they've taken that technology to rural areas of Appalachia. You've got hospitals like Marietta and Orange County and Gallia County and Scioto County and places like that, where those neonatal cardiac thoracic surgeons can go through a telehealth session and talk to a physician, a surgeon, or a pediatrician that can help identify a problem, and as you can see, the outcome can be very different. The sky's the limit here, folks, and we're in the right place at the right time to make a difference. In December, a Forbes article cited an analyst's prediction that the U.S. telehealth market will grow to $1.9 billion in 2018 from the $240 million that it is today, an annual growth rate of 56%. Those are astounding numbers to consider. Now, if I had an IT company today, I can tell you where I would be heading toward. I'd certainly be looking at this tremendous opportunity to not only create jobs, but to further spur healthcare innovation. With needs so demanding and real solutions at our fingertips, we're at a critical juncture in the medical industry, and we must choose to harness the momentum. Now, we know that we have significant challenges ahead, such as how to utilize telehealth across state lines without licensure recognition between the states, or how to reimburse providers for the provision of telehealth services, and of course, determining the specific roles for the states and the federal government in moving forward with policies to resolve these issues. But I am very encouraged by discussions being held and progress being achieved by both the states and here at the federal level. And today's discussion is testimony to this progress, because we're talking about it. But there's more to do. I'm sure you're all aware of efforts by the Federation of State Medical Boards to create an interstate compact for physician licensing for the purpose of interstate telehealth. And I applaud their efforts and those of the states involved. Just like all of us engaged in the healthcare sector, states are realizing that telehealth is having and will continue to have a profoundly positive impact on U.S. healthcare. As my colleague, Congresswoman Matsui mentioned, states are recognizing this potential and moving to draft telehealth policies. Unfortunately, therein lies one of the biggest problems, often adding to an existing patchwork of state laws. Doris talked about that. And this ultimately hinders progress in telehealth. And this, too, is one of the big challenges that we have to overcome. And I'm grateful to Representative Matsui for offering me the opportunity to lead on this issue through our introduction of the Telehealth Modernization Act, because by establishing a workable federal definition of telehealth, and that's all it does, is establish a definition of telehealth. I'm hopeful that states will look to this legislation for guidance in developing clear and consistent telehealth principles and policies that benefit the nation as a whole. Again, I want to thank the Information Technology and Innovation Foundation for inviting us to be here today to discuss our efforts to streamline the U.S. regulatory framework in an effort to unleash the tremendous potential of technology that telehealth brings to America's healthcare system. And with that, I think we're going to open it up for a few questions, right?
Absolutely. Thank you.
Okay, thank you. I appreciate being here. Thank you very much.
Please, if you have any questions, Congressman agreed to stay for a few minutes, and then we're going to launch into a panel discussion.
Yes, sir.
I'm Peter Bosma from the Netherlands Embassy. I would be interested in what you mentioned about this interstate license and that there would be a solution for that. Could you elaborate a little bit more?
Well, the problem right now is that every state has a different set of rules about licensing their physicians, who can provide what kind of services, who can provide other kinds of services. Some states, for example, have different rules and regulations for what a licensed physician assistant or a nurse practitioner can do. Rules on how physicians are reimbursed. So let's say you have a patient in California and the specialist is in New York. How does that specialist in New York, first of all, is he licensed? He might be licensed in New York, but he's not licensed in California. Can he provide that service? And if he does provide the service, does he charge according to California's rules, or does he charge according to New York's rules? Those are some of the kinds of things that the states need to work out. I want to make sure I'm very clear. I see the federal government creating an atmosphere, bringing the dialogue to the forefront, creating an environment where the states can put this all together. I'm not big on the federal government telling the states with with a whip. You'll do it this way and you'll do it that way. I think we need to let the states have a major voice, the major voice in how these policies ultimately come about. But this legislation that we're talking about today is, again, designed to start the conversation by defining what telehealth is.
Ozzie Diaz from Intel Corporation. Congressman, are you aware of any public-private partnerships going on to take potentially these demonstrations that you've seen in Ohio and replicate that across the country and scale that up?
You know, I'm not off the top of my head, but I think once this legislation goes through and the states begin to talk about telehealth from a common framework, I think you're going to see those kinds, especially when the private part of that partnership sees that $1.9 billion annual price tag, or not price tag, but revenue stream. They're going to want to be a part of it. But right off the top of my head, we'll take that question, and if we can identify something, we'll get it back to you. Okay.
We're about Communications Daily. What, if any, privacy concerns do you have regarding telehealth, and would this bill do anything to address this?
Well, the same privacy concerns that we have about healthcare in general, and you know, this is not a discussion about the current privacy issues surrounding our government's mandates on healthcare. But suffice to say that privacy has got to be a concern. You know, we've got hackers that hack into our databases. What's to keep some malicious intruder from hacking into a telehealth session and getting access to information that they're not supposed to have? We have to be concerned about that, and certainly from a technology perspective. But that's actually from a technological perspective. I can tell you folks, if you ever think that the issue of information and data security, network security, is ever going to be one that we're going to be finished with, it's not going to happen. It's going to require continued due diligence. Remember what I told you, computers can only do two things: add ones and zeros together and shift them one direction or another. And as long as that's the way computers work, you're going to have people out there that like to cause trouble, like to steal information, know how to program software using ones and zeros, and they're going to find a way to try to do things that they should not be able to do. So network security, privacy, those kinds of things are going to have to be foremost in any policies that the states develop.
Sir, Rich Brennan from the National Association for Home Care and Hospice. Currently, 28% of our agencies employ telehealth remote patient monitors as part of their service to both Medicare and Medicaid populations. However, they're not, in many respects, paid for that because there's underlying definition in Medicare that it has to be facility-based technology. And we know, in working with partners such as Intel and Bosch and others, that this technology is ready to wear. In fact, people go around with Google glasses now. So how does your bill address this as far as the modernization of the definition of this technology? Is it expansive enough to say that this technology can basically happen?
Certainly it recognizes, I think by definition, I think that the legislation recognizes that a physician does not have to be in the same room with the patient or the healthcare provider, not necessarily a physician, but the healthcare provider doesn't have to be in the same room with the patient if we use technology to bridge that. So I think it starts that conversation, absolutely.
Really appreciate you being here.
Well, thank you very much. It's good to be here. Thank you for letting me be about 3 inches taller today.
we appreciate you did this in person as opposed to virtual.
Oh, I am too. I am too. Thank you all very much.
Thank you. So now we're going to launch into a little bit of a panel discussion on this issue. We have two experts joining us today. Kofi Jones is Vice President of Public Affairs for American Well, which is a national mobile and web-based telehealth solution provider based out of Boston. Kofi right now is doing a lot of work on the ground trying to get over these barriers that we have at the federal and state level, as well as promoting the benefits of telehealth and introducing this technology to many users. Also, we have Krista Drobak. Krista is Senior Policy Advisor in DLA Piper's Healthcare Policy and Regulatory Group, as well as Executive Director of the Alliance for Connected Care. She was previously Director of the Health Division at the National Governors Association, Center for Best Practices, and was a Senior Advisor at the Center for Medicare and Medicaid Services. And before that, you spent quite a bit of time on the Hill advising members on these issues, so we appreciate both your expertise. Why don't we just go ahead and jump right into this, and Kofi, you want to start us off?
Sure. Good afternoon. I want to thank ITIF for having us here and the Congresswoman and Congressman for their comments. It's really exciting to see two members of Congress on both sides of the aisle to being this kind of excited and getting it, I'm usually loud enough anyway. It's really exciting to see both of them so invigorated by the concept of telehealth, getting it, understanding its value. As Daniel said, I'm the Vice President of Public Affairs for American Well. We were founded by two doctors who were also brothers, who wanted to marry technology and innovation and find ways to bridge gaps in our healthcare ecosystem. And what they developed is very simple. It is a telehealth platform that lets providers and patients engage in real-time, synchronous, audio-visual healthcare encounters online. It can happen anywhere, at any time, from any location to any location. Since launching our platform in 2006, it has been deployed by national healthcare plans, national employers, the U.S. Department of Veterans Affairs, hospitals, delivery networks, pharmacies, all across the country. And I think we've been successful for a number of reasons. There's a natural inclination in our nation to innovate when we have challenges. We move towards innovation just to solve our issues. And if you bring together innovation, technology, and healthcare, that's what telehealth is all about. It's just a natural progression for us to get here. Just like it was a natural progression for us to stop buying books at bookstores and order our clothes online. It was just kind of meant to be. I think the second reason is timing. Millions of people flooding the system from the Affordable Care Act, baby boomers retiring, and a lack of access, just not enough providers in the ecosystem. And telehealth can solve those issues of access and while still addressing issues of cost by moving care to a lower cost environment. So those kind of stars just lined up for us. And I think the third reason is kind of some of the decisions that we made right off the top around our product and our policies around our product, kind of our philosophy. We don't look at telehealth as a different type of healthcare. We think of telehealth as just a different modality of care delivery, just a different way to deliver the same kind of healthcare. So we treated it very much the same. So we created a platform that as much as possible mirrored what happens in a face-to-face encounter. It's HIPAA compliant and secure. There was a question about security and safety, so it was a HIPAA compliant environment. It's documented. There's a full documentation of the encounter. It's audio visual, so the provider can see the patient, hear the patient. It can be integrated with biometric devices, so you can see the ear or the skin. It supports continuity of care, so it can integrate with medical records. So we created this kind of infrastructure built into the system, so a physician can use their same, or any other provider can use the same discretion he or she would use in a face-to-face environment. And that really helped kind of create this situation where you don't think of it as this is something else. It's just healthcare delivered a different way. So yeah, telehealth is really on the rise, and you see, 20, 30, 40% growth every year. You see more reimbursement happening, both public and private, which is exciting. You see new use cases all the time. Behavioral health is huge. The VA has done tremendous work there. A lot of chronic care, where telehealth is a remote patient monitoring. But there are a lot of barriers that exist to making sure that this really gets to reach its full potential. We talked a little bit about licensure, that the provider has to be licensed in the state where the care is being delivered, not where the provider is. And, up till now, providers have kind of been licensed where they live. Well, they might be treating patients in 8 different states, and they've got to be licensed where the patient actually is, and then what if the patient is traveling? So it's complex. And I think conversations about that are very important. There are a lot of conversations about reimbursement. There are about 20 states in the District of Columbia that have mandated commercial reimbursement, about 46 states now that have some kind of Medicaid reimbursement. Medicare with the originating site requirement that the patient still has to get in the car and drive to the hospital or federally qualified health center, when clearly those are not necessarily the lowest cost environments. Care in the home, care in the workplace, so the originating site requirement still has the handcuffs on telehealth. Another important conversation. So there need to be reforms there, no doubt, but I would contend that you can't reform that which you cannot define. And we have not yet done a full and complete job of defining telehealth. There are 50 states. Each one has at least one definition. If they have commercial reimbursement, Medicaid reimbursement, and a medical board and pharmacy board stance, they might have 4 definitions. So we could look at 200 different definitions that exist in the country. So it is really inconsistent when you're talking about a tool that knows no state bounds and could help balance supply and demand and need between states. So I would say that our first step is to really talk about defining this tool that has such great potential, particularly when you're talking about medical boards. And there are 50 medical boards which basically set forth whether or not a provider can provide care in this manner. It's extremely difficult to interpret. And many of our partners who want to provide care in this manner ask the question, can I do this? Is it legal? Can I reach out to my existing patient? Can I reach out to a patient who doesn't have a provider? Is it even legal? And the answers are oftentimes extremely hard to give, because it ranges from, yes, you can, but only if I've seen you before in person. No, you can't unless there's somebody sitting next to you. Yes, you can, but you can't prescribe, not even antibiotics. And many times it's because the rules haven't been updated in the last 10 years and they haven't caught up with technology. So it makes providers really hesitant to provide care in this way and help fill gaps. It makes national employers impossible to offer it to all of their employees since they're all over the country. And it makes consumers unsure if they're receiving safe and secure care. So that's why we're really excited that Congresswoman Matsui and Congressman Johnson have proposed the Telehealth Modernization Act, because it creates a federal definition that is not a state preemption, but guidance to states who are looking at the question of what is safe and secure telehealth, what is it? A lot of states are already thinking about this question, and this gives them a way to think about answering it consistently. A lot of federal organizations are already thinking about this question. The Federation of State Medical Boards is doing work around creating state guidance. The AMA is thinking about this. The American Academy of Family Physicians is thinking about this. Our Friends of the Alliance for Connected Care is thinking about this. So this is really where things are heading. And we think it's important work. It's a great bill. It does answer questions about security and safety and consistency with standard of care. It's very comprehensive. So we're excited. We think this is the right direction to go to at least start to answer the question, can and should we be doing this? Telehealth's not the only answer, but it's definitely going to be an answer to a lot of our healthcare problems. And again, thank you for having me here today. I look forward to the discussion.
Thank you, Kofi. Krista, can you spend a little bit of time talking about, the challenges that you're seeing on the policy side and how we're approaching them?
Sure. So the Alliance for Connected Care launched 2 weeks ago. I work with Senator Daschle, and he and former Majority Leader Trent Lott and former Senior Senator John Rowe got together because they're all from rural states, so they all had experience with telehealth, but since they've left Congress, they have been exposed to technology that they didn't know existed and have seen the possibilities for telehealth and are excited about it. And so they don't just see this as a rural issue anymore. And so they formed the Alliance to really raise the profile of telehealth among policymakers. Because actually, I'm probably speaking to the wrong audience in this because you're all here, so you care about telehealth. But in most Hill offices and in the administration and even in some governor's offices, telehealth falls to the bottom of the list. It's on the list, which is good, but it's generally not something that people are very urgent about. And if we are talking about mobile apps or wearables or other things, members of Congress are, very hesitant to get in the way of innovation or progress because consumers are using apps and they're excited about them. And so, the policymakers don't want to get in the way of that. But when it comes to telehealth, we can't see it take off unless we update our regulations and our legal structure. And it's been 13 years since we implemented 1834M. And just for kicks, we looked online at the top of the line mobile technology available in the year 2000. And we blew up a big poster, and Senator Daschle brought it with him to the Alliance because it brings into stark relief the reason why it's so clear that we need to do something about this, because the technology that was available in 2000, one of those big clunky flip phones that has the green background, that we all remember, and now we all basically carry around a personal computer. So there are so many consumer use cases for this. Rich brought up home health and remote patient monitoring. It's so obvious. I'm a working mom, so I deal with pink eye and ear infections, and I don't want to leave work and go across town and get my kids and then go to the doctor. It's a half-day affair, So there's a lot of use cases now that we didn't think of before, or we didn't have FaceTime, readily available, or a HIPAA-compliant, secure platform like American Well has. So really, we're here just because it's time to change this. And so our main mission, in addition to just raising the profile among policymakers, is to do a comprehensive change to 1834M. If you have time, it's only a couple pages, it's pretty short, but it's very clear. Alice, that Congresswoman Matsui was talking about, she couldn't actually talk to a specialist from her home. She had to travel to what's called an originating site within her district in order to actually communicate with that specialist. And again, with neonatal issues or anything else, you have to be in an originating site, which is just sort of anachronistic. You should be able to do this from your home. So the last thing I'll say is we are releasing a literature review, hopefully at the end of March or early April. That is a review of all the literature back 13 years, because what we're trying to show is, it's not just about turning on a code, saying we're going to reimburse for telehealth services now. It's about looking at the other side of the ledger too, and the kinds of reductions in inpatient hospitalizations and other more expensive procedures that we're going to see on the other side of the ledger, because we have to show the evidence that this can actually improve access to care, maintain quality, and potentially reduce costs, because otherwise, obviously, CBO will just say, well, if you turn on the code, you're going to get a lot of utilization, and it's going to blow the budget. So our next step is really to demonstrate the evidence. Not only are we doing a review of the literature around chronic disease back 13 years, we're doing a super review, so a review of reviews of telehealth, because there have been so many lit reviews. We're going to do sort of a summary of the lit reviews, in addition to looking at some of the peer-reviewed studies that are rigorous in their methodologies around chronic disease. So Look for us in end of March, probably early April, given that we're dealing with some academics. They don't like to be nailed down on timelines, so early April we'll be up here with that evidence as well as demonstrations of some of the existing technologies. So we'll be doing a House and a Senate side briefing.
Great, thank you. So why don't we talk a little bit about the technology some more, because I think until you've had a chance to kind of sit down and use it, it's still a little bit of an abstract concept. It strikes me that so many things that we take for granted now have changed dramatically in the past 10 to 15 years. I mean, online education, online dating, all of these online shopping things that we do. 15 years ago, those didn't exist. People didn't even think that was possible. And I think today, when people think about going to the doctor and actually think about having to travel and do all these things, and walk us through a little bit about on the consumer side, what's the convenience factor there? How will this kind of change the experience? Not only just in terms of all the benefits we're seeing in terms of cost saving, but just in terms of the actual experience.
Well, the easiest way for me to explain the experience is to say that anybody in this room that has a smartphone right now can see a doctor within the next 4 minutes. Download the app, select a doctor, and the average wait time is 3 minutes. So, you can all speak to your personal experiences and how long it takes to get a doctor's appointment. I mean, average wait times actually where I'm from are 6 weeks. So I think that's the best way to actually discuss how it changes lives for consumers. If you're a parent and it's the middle of the night, you're a crying child and you don't want to go to the emergency room, but you don't want to wait all the way until the morning. I mean, it's about immediacy. So that's one piece, just the immediacy. I think the other piece is that, we're talking about specialty care. The wait times for specialty care are tremendous. And we have communities that don't have access to these kind of specialists. And we've had stories from individuals who literally have to travel days or just not have access to the care. And this kind of technology allows to deal with the supply and demand so that, a pediatric neurologist can actually project their care anywhere in the nation. So that for a family that needs that, there's no way for me to quantify the value there. For physicians who are thinking about leaving the workforce but still want to do some work, quality for them is through the roof. They want to stay practicing a couple of days, but they don't want to be full-time. We're able to keep more providers in the workforce, which is so vital right now because we're hemorrhaging providers. So it's a complete game changer in that way, shape, and form, not only for providers, but for patients and for the entire system. But I would encourage anybody, next time you actually are looking for a doctor's appointment, 3 minutes is faster than 6 weeks.
It's interesting because the consumer experience with technology really matters. Because I think before FaceTime or Skype, it would have been a lot harder to make this argument because it wasn't something that we were familiar with. But as people get more used to face-to-face technology, it makes it more real and the opportunity is more real. The problem is that who's covered by it right now. So what Kofi's talking about, if you're a WellPoint beneficiary, you have access to it. If I'm a DLA Piper employee, I have access to it because my company has a contract with the telehealth provider and the employer defrays some of the cost. If you are in one of the 45 states that has Medicaid that covers it, you have access to it. There are 40 states that cover telemental health services, so you have access to it. If you're in the VA, you have access to it. So the challenge is that you don't have it in Medicare. So, and obviously we have a lot of people with chronic disease and actually difficult time getting around that don't have that opportunity.
I might add that, it's true that in a lot of those states there is Medicaid, but most of the Medicaid policies unfortunately have mirrored what Medicare has done. So there's still not a lot of reimbursement going on in the home and the workplace. So that identified in 1834 was key to this discussion because we still have major originating site issues with Medicare still forcing people to get in a car and drive to an originating site. Oh, and by the way, it has to be a rural originating site. So no homes, no workplace, and no cities. So huge loss opportunity there. And unfortunately, many states who have the freedom to define their own telehealth reimbursement policies are mirroring what Medicare is doing. So even those people in those states are not getting reimbursed for home-based care or workplace care.
At the risk of never giving Daniel the chance to ask some other questions, let me just add one more thing. That a couple of our members, CVS and Walgreens, are implementing telehealth in their retail clinics. And I don't know if you've ever been to one, but basically you go and you wait in line and you get to see a nurse practitioner about general needs. And they want to have the ability to consult with specialists and physicians over telehealth. But the problem is that they don't fall in one of the, first of all, they're not a bridging site because they're a retail clinic, which is not on the list in the statute. And the second thing is, even if they were, they would have to be in a rural area. So it's a convenience issue all around, not just from your home, but if you want to go to a retail clinic.
And I'm sorry, I noticed one more thing, just about who has access. There are several telehealth solution providers that have made access to care, have provided directly to consumer. We're one of them. There are others, but it is available to consumers who don't have coverage. There's a price for the consultation, what have you, but there is a drive towards a direct-to-consumer push so that there is an ability for those who don't have insurance and whose insurance does not cover to actually have access to this care. So it is, but it's not covered.
So I want to just spend a minute talking about the state licensure issue, because this has come up a lot. I guess if you can just start by just talking a little bit about why we find ourselves in the state we are today with, these various good states. Why did the states have the policies that they have today, and what will it take to change it, particularly in the context of what the state should be doing versus what the federal government should be doing?
Well, I mean, it's not ridiculous to think that a state medical board wants to oversee physicians that are providing care in their state. I mean, that is not an unseen thought. They collect fees for that. They promulgate regs, and they oversee the physicians that are providing care there. For a very long time, it didn't make sense really for physicians to be licensed in more than one state unless they lived somewhere near the border, or they maybe got licensed in a couple of states and maybe provided care in a couple of states. But we're living in a very different environment now. Care is being projected throughout the country. There was, and helping with how many years ago was that there was a nursing compact that helped for nurses to be able to get a license in one state that was acknowledged in multiple states, and 24 states have come on board the nursing licensure compact. There's now an effort to take a look at a similar type model that would allow for a similar thing for physicians. It will take a lot of agreement between state agencies and a lot of gubernatorial support, I believe is the way it's looking right now. Is that correct? For that to happen.
So the effort that she's referring to is the Federation of State Medical Boards. So for years, right now in the VA, for example, you can practice with one license, but it's a closed system, so it makes sense. So people said, well, why can't we do that in Medicare? If you're practicing on a Medicare patient, how come you can't just have a national license? So there is a bill for that, municipal loan. And the back and forth has been, well, we should let the states try to solve this problem instead of having a federal solution. So the Federation of State Medical Boards got 20 state medical boards together, and they wrote a compact. The nursing compact is reciprocity. So if you are in Illinois, you're licensed in Illinois, you want to practice in Virginia, Virginia's part of the compact, Illinois is part of the compact, you can practice in Virginia. The FSMB effort is the creation of a commission. So instead of reciprocity, all they've done is created a commission that you still have to be licensed in Illinois and Virginia. The commission is just layered on top and is supposed to try to expedite the application in Virginia. The challenge is that the systems are not there, so it's all paper-based. So it's not clear how, if I'm a doctor in Illinois and I want to practice in Virginia, I have to still petition my Illinois medical board to help me send paperwork to the commission, which then would expedite my license in Virginia. So, and they say it's going to be real time. So we're still looking at it, and if it could happen in real time, it would be fantastic. But go ahead, sorry.
Let's be clear, even if they solved that and cracked that nut, even if hypothetically there was one license that works in all 50 states, if all 50 states have different rules around what is clinically permissible, what good is the license? If there's no clear guidance on what is permissible for physicians to do, no definition, no idea about what is permissible. If you have a license that works everywhere, but there's a different rule, what is the purpose of resolving the licensure?
Okay, let's open it up to questions, please.
We've talked about the domestic, what about international? The U.S. is a leader in expertise in certain medical practices. Are there issues with treating patients remotely in other countries?
There are. And I will admit that I spend the bulk of my time focusing on at home and 50 states and the federal landscape, but there are different rules. In the EU, interestingly, licensure works the other way around, so it's where the patient is, and that helps solve the licensure piece. We don't have that privilege, but there are different rules around prescribing that make it much more complex. And then international waters play a whole other role. So if you're on a cruise ship, there's a whole bunch of other things you have to take into consideration. It gets very complex. So yeah, there's a whole nother, and every licensure seems to be a consistent issue where you've got to be licensed, and then some of them have rules around needing to be residents for the 6 months before you get a license.
One other thing we haven't mentioned that's important about a license is there has to be somewhere where the physician can be disciplined if he or she injures somebody, you know. So it is difficult if you're a physician in Illinois practicing in Virginia, if something happens, if harm comes to a Virginia patient, you don't want to have the patient file against the practitioner in Illinois. So it does make some sense.
It does make sense to have oversight where the patient is to some extent.
Sure.
So, would you see a race to the bottom, like in financial markets, where you get Jersey Isles types of things, or national flagging from shipping, where they go to Liberia? Do you see anything like that on the international? Because you get to the race to the bottom kind of.
Yeah, I don't personally see any change in physician-based licensure. I don't think any state, I mean, the doctors themselves don't necessarily want to make it easy. So
Yeah.
I don't think that, I mean, unless a bill passes Congress to make it a national license, in which case the federal government would become the regulator, there's going to be regulation either at the state or federal level.
Krista, can you address in your comments the need to unlock this rural sort of cognition of the definition, how it's been prescribed, mostly for the rural areas. Telehealth answers a lot of the 3 A's as far as value and care coordination and patient engagement, community cost savings. So how do you prescribe as far as how this technology then gets used in urban areas, other places where it would be of value that necessarily people are looking towards a change in this definition?
Well, I think there's 2 ways it could happen. One is that you just start reimbursing for it and people will use it. The other way is through alternative models of care. So we are moving slowly, but we are moving away from fee-for-service. And to some extent, there will be more accountability for providers in an episode of care. And in that case, it doesn't necessarily have to be directly reimbursed, because if you find that remote patient monitoring or telehealth can reduce your cost of care, total cost of care for the patient, you'll use it and you'll pay for it. So my own mother, sometimes I like working in healthcare because you can actually have an experience that my mom, I was on the phone with her on Sunday morning, she just had a knee replacement, and she said, I have to get off the phone because at 9 o'clock the computer's going to call. And I said, what computer? And she, we were on FaceTime, and she showed me the Honeywell device on her bedside table that was going to call her and take her vitals. so that it could be then uploaded into a cloud and downloaded at the provider's office so they could monitor my mother. So apparently this computer calls her twice a day. And I thought, how is this happening? Because it's not reimbursed. So it turns out my mother is in a Medicare Advantage plan. And Medicare Advantage is a mandatory supplemental benefit in Medicare Advantage, which means they don't actually get paid for it, but it's included in the benefits that are covered by your copay and your deductible. So the insurance company is getting paid for it, and then they use that money in the copays and deductibles to pay for supplemental benefits. So CMS, that's as far as they think they can go, because they believe that they're restricted by the statute. So they can make it a mandatory supplemental benefit, but that's only if you're in an MA plan. So if you're in a fee-for-service Medicare plan, you would not have the computer calling.
Great, so we're almost out of time. We can
Yeah, I did a follow-up. Most of our agencies that are using the technology, as far as like literally 60% of that are adopted are hospital affiliated, and we feel like that can be attributed to the need for reducing emergency room visits and unplanned hospitalizations. Can you speak to some of the necessary tools that can be used as far as the stick approach to necessarily also tackle this problem?
First thing we need is really clear evidence, we think. We think we need a definitive document that says, here's the evidence that shows that doing these, reimbursing for these things can actually improve access to care, maintain quality. That's why we're now where we are.
Right, because we're fighting the idea that eliminating those words, originating site, is somehow going to be a driver of increased costs. And given the nascent industry that we're in, there hasn't been this comprehensive overview, shared data. The VA has done the best work, right, around the numbers. But given that that's a closed system, what we're really needing to demonstrate is more access is not going to mean more cost, because we're talking about lower cost environment, better chronic care management, et cetera, et cetera. That's what I think.
Just in closing, can you talk very briefly about the competition aspect of this? Because it strikes me that in areas where we've seen really integrated technology like Uber, suddenly you have consumers choosing drivers based on their rating, have better feedback. Talk a little bit about how this is changing telehealth.
What we're experiencing in the competition? Well, that's an interesting question. How am I going to answer it? There are a lot more players in the field. Every year we see new competitors come on board. I think that there's a huge spectrum of telehealth out there. There's phone-based care, there's email-based care, there's questionnaire-based care, and then there's synchronous audio video-based documented HIPAA compliant type. So there's all over the spectrum. I think what's going to shake out is the policy is moving in the direction of supporting care that, as we talked about earlier, really can serve populations across the country, can mirror what occurs in a face-to-face encounter, can be secure and safe and scalable, can serve delivery networks, can serve small practices, can serve hospitals, can serve health plans like WellPoint's doing, and has the ability to, there's a huge drive to make sure anything that is coming out in the market can integrate with health records, can document, can support PCMH models. So that's where momentum is going, and I think as a result of that, you're going to see some of the other platforms that are out there not continue to have some of the success that they've had. The other thing that we're finding, and this is a lot of the work that I do, is medical boards have a clear preference around how they want to see telehealth done and what they feel comfortable with. So I think as they become more active in the conversation, you're going to see some telehealth providers have to either change or get out.
Great. Well, thank you both. And I just want to announce next week I have to be releasing a report on telehealth. We'll be looking at what the benefits are and enforcing recommendations on how we can move forward on overcoming these barriers. Please join me in thanking